Everybody, thanks for joining us. I'll give another minute or so for people to trickle in, and then we'll get started. All right, we'll get it going. So thank you everybody for joining. This is GOMI, if you have not been here before, which is our free wilderness medicine education series. And this is our final talk of the spring semester. So thank you for joining us. If you haven't heard yet, our mission is to create this educational platform where everyone can learn about all the really cool things in wilderness emergency medicine, both locally, nationally, and around the world, and to do this in a way that is promoting a diverse and culturally competent environment. This has been all the lectures we've had so far this year. And like I said, this is our final one. So keep an eye out for our lectures that are coming in fall of 22. Check these out on our website. You can find the archives of all these awesome lectures. Last week, we had Luca Parmitano, who is one of the astronauts from Italy, which was a super cool lecture on his experiments in the space station. So check that out. And follow us on Twitter, Instagram, and check out our website just to keep up to date with what's going on for GOMI. And here's our mailing list. If you want to snap that with your phone, we'll put it in the chat. You can also join from the website. All right, so it's my pleasure to introduce Dr. Tiffani Brainerd, who is from my institution. So she's an anesthesiologist and peds anesthesiologist at Vanderbilt. She divides her time between clinical practice in the Nashville area and her home in Durango, Colorado, where she is medical director of La Plata County Search and Rescue. She served as medical director of the North America Ice Climbing World Cup Series and was recently named to the board of directors for the American Institute of Avalanche Research and Education. Dr. Brainerd is formerly faculty at Harvard and completed a DIM and FOM through the WMS, the University of Colorado, and University of Utah. She was raised in Florida and is now converted to a rock and ice climber, backcountry skier, trail runner, mountaineer, and has summited many notable peaks, including Aconcagua, which is the highest peak in the Western and Southern hemispheres. So I will stop sharing and pass it over to you. And other thing that Dr. Brainerd asked is if you could just put in the chat where you're from, what your kind of medical role is, whether you're an EMT or nurse or medical student or PA student or whatever, where you're coming from. And then at the end, we'll stop the share and love to see people's faces while we do a Q&A. You can put your questions in the chat and we'll archive them, or at the end, if you want to just raise your hand, we'll let you speak it out loud. Before Dr. Brainerd.
Awesome. Thank you so much. As Alex said, I'm Tiffani Brainerd. I'm an anesthesiologist and a pediatric anesthesiologist at Vanderbilt, which is in Tennessee. And I work in Nashville and a few of the other more recent acquisitions for Vanderbilt, so in the Nashville area. And then I split my time with home in Colorado, which is where I love to be and do all kinds of outdoor good stuff, and where I participate in mountain rescue. A few disclaimers of my own, no financial or conflict of interest disclaimers or disclosures, but I am healing, unfortunately, from an ACL. We were heli skiing last month and in some terrible conditions. Really had no business being out there that day, but regardless, so I'm not at my normal post, and you might go for a little bit of a rocky ride with my camera because I've got the leg elevated, and so your laptop this evening. So I appreciate your patience with that. Wear a lot of hats these days. Sorry, you might be able to hear some train noise. There might be some other background noise, and I apologize if that's distracting. Medical director for La Plata County Search and Rescue, was recently named to the ARI board. If you've ever taken an avalanche class or done what sometimes is referred to as your ARI 1 or ARI 2, that's that organization in the US. So I'm really pleased to be joining them. My term for them starts this October. medical direction for the UIAA Ice Climbing World Cup Series, which is a little bit stalled right now. I've been a WADA tester, which is the World Anti-Doping Association, specifically for ice climbing in the US. That's the same organization that does the drug testing for the Olympics and the other international regulatory bodies. I know that you guys have had some talks on the DIM and on Wilderness Medical Society in the past. So if there's time, that's probably best question oriented than me presenting material on it, but I'm happy to talk with you about that. I don't have, again, any financial interests with them, but I certainly have had very positive experiences with WMS over the years, and do hold that DIM in that FOM. And we can talk a little bit about pros and cons and why you might want to do that or might not, and which program. They're kind of becoming a little bit melded, and we're seeing a lot more cooperation between the two programs now. But at least at the time when I took it, there was a program based out of University of New Mexico, which was not as closely associated with WMS, and then the WMS program affiliated with University of Colorado and University of Utah. So we can talk a little bit about those programs if you'd like later on. And yeah, I just want to thank Alex again for the invitation. We're not going to be super slide based tonight. I've got a couple sad case studies to share from situations that I've been involved with, rescues and recoveries with our program. I had a little bit of a hard time, fortunately or unfortunately, paring down which, figured we'd talk one avalanche story and one non-avalanche story. And we have a lot of avalanches where I live. And so that's a lot of the basis of my work is geeking out on that information. So I had so many case studies to pull from, but we've, pared it down to one, and we'll talk a little bit about that tonight too. So I will go ahead and jump in. And thanks again for keeping track of the information coming in from folks as far as their locations and what they're doing and what they're up to. And so after we get through this first little anecdote, if one of you don't mind, our brave administrators this evening, thank you so much for the board for doing this. If you don't mind kind of giving me maybe a synopsis of kind of a breakdown of who we've got on and where they're from and what their interests are. Sorry about the alphabet soup down there. So MD, FAAP, FASA, the FOM, the DIM, lots of stuff. It becomes too much, but obviously, yeah, medical degree. FAAP is my affiliation with the American Academy of Pediatrics. So just hold a fellowship with them due to the pediatric anesthesiology subspecialty training and separate board certification. And then our FASA, which is our national program with anesthesiology. Alex wanted me to talk a little bit tonight about anesthesiology as a potential alternative to the typical emergency medicine path for associating with wilderness medicine. And then I think you guys are familiar with the FOM and the DIM. It's just one of our recent trainings, getting to be on the sharp end of litter attending over one of our big, beautiful gorges in our area. And then this is one of our local peaks, little winter ascent on Engineer. We've had some pretty big rescues from cornice collapses and some fatalities on this peak in the winter time. So you definitely need to know when to go up there and when not, and be mindful of the conditions and avalanche risk at the time. I want to talk a little bit about Ben. This is a 26-year-old. He grew up in Kansas and was living in the Denver area. Mega athlete, had run track for Kansas, and he'd finished all the Colorado 14ers, so 58 of those peaks, and he was now working on his centennials and his bicentennials. So those are folks who are looking to bag all of the top 100 named peaks in Colorado, and then some go on to do all 200 of the top, and pretty, accomplished athlete. He had been out grabbing some more centennials and bicentennials. Here's some old photos of him doing some scrambling and things, and had gone missing, and family hadn't heard back from him. They knew roughly a little bit about his chosen path for that day. He was out on a solo jaunt. This is him on top of a Grand Teton not too long before this incident in October of 2020. And they were still having trouble finding him. And the family wasn't too happy with the response that they were getting. The local SAR team is excellent, and a little bit under-resourced for what his last known location was. And of course, not sure how well versed you guys are in those search techniques and things. We have entire groups that work just on search strategy. But basically, there was a little bit of cell phone forensics and a few things to go off of, as well as knowing kind of what his general plan was for that day. But it's incredibly difficult terrain, and it can be really hard to find people. And so the searches so far that they've been working on weren't producing any information on where Ben was. And basically, we got a call through the state agency to our to La Plata County asking for mutual aid support. They wanted to bring in multiple folks to try and gear this up. And so we were making a plan for the next day. Lake City, which was the closest town to where they thought Ben's last known location is, they share a mountain range with us, but in order to get there, it's several hours away. And so we were making a plan for getting there and working on this the next morning. And in the meanwhile, we got word that a private helicopter pilot that the family had chartered had made a sighting. And of course, don't know for 100% if that's Ben or not, but they certainly had a suspicion that it was. And so myself, another teammate from La Plata County, somebody from Ouray County Rescue, a member of the Western State Rescue, and then one local from Lake City, met with the helicopter pilot. Forgive me, during this and another story I got to tell, some of the bits are hard, just interacting with the families and things. It's really sad, but we'll push through. But apologies for if at times it's hard to understand me. So load us up in the heli. Of course, these are at altitudes that are just shy of 14,000 feet. And so we do definitely have to modify our helicopter operations for these kinds of things. In fact, our agency has had 2 helicopter crashes in the last 20-ish years. And so, something to be mindful of, the excellent tools of the trade, and we use them a lot, but not without risk, and especially in this awful terrain and at high altitude. So, but accomplished pilot, none of us had specifically flown with him before, but we knew a lot about him and his qualifications, and he had stripped his bird in order to get us up there. So kind of had a modified, pseudo landing zone that we could work with for some hot loads, not too far from where he'd identified this flash of color that looked unnatural in the mountains and that just maybe could be Ben. And he was able to get us, I don't know, it was, several hundred maybe vertical feet below him. And so a little bit of a technical ascent to get up and find what was Ben. Looked like he'd taken a large fall off of a ridge line, which is not hard to imagine when you see, some of his the scrambles that he tended to enjoy, as evidenced by this picture here. I'll try and tell you a little bit about that recovery. The rotor on this video is a little loud, so apologies if you have trouble hearing me over it. Basically, heli dropped us off, took us a little bit to ascend to the location, and because it's so vertical, we needed to build ourselves a platform so that we could work. This is a little bit of an idea of the terrain in which our teams are functioning. I'm there on the right. Our teammate out of Western State is on the left. From this camera angle, it's deceiving. It's actually steeper than it looks. So basically, if you shift your body forward to try and grab what the helicopter's got there, then you'll go tumbling down the ridge side. This is after we had anchored Ben's body, prepped him for recovery. Windy conditions, it's amazing that the pilots can target things so specifically for us, but you can see it takes a minute to get that. And then you have to be careful when the heli are dropping these, because they can tend to grab a bunch of static electricity. And so you got to be careful when sometimes you get quite the shock. And then there, unfortunately, fortunately or unfortunately, Ben is off to a trailhead where his family was waiting to identify him. Time and time again on these recoveries, we find that the families really want to see their loved one, really want to see them right away, even if we haven't had an opportunity to kind of, I don't want to say clean up, but kind of either prepare them for what they might see, or to or to kind of clean up the situation a little bit. And I can't imagine for those families what those lasting images are, for Ben's parents to see him in the state that he was. It was evident that he, did not suffer, which is great, but really hard for a family member to see those things. So that's kind of a lot of the work that we do. Unfortunately, it does involve, for us, a lot of body recoveries, especially when you're talking avalanche work, which is a bit notorious for us in the La Platas and specifically or more broadly, in the San Juan Mountains. There are all kinds of statistics, and I won't throw them out there because it depends who you talk to, what they quote. But our area of the country is very high in avalanche activity. And so we have a lot of avalanche incidents, fatal and not. And so those are a lot of our responses. Relative to other teams, our call volume is actually surprisingly low. This is just a cool spot, not too far from us outside Telluride. We had just descended a little technical climb called Lizard Head, really chossy rock. I can't actually recommend that you go up there, but it was something to do once. And some of our beautiful area alpine lakes that we've got in our zone. If you're talking about Colorado teams that are more, located in the Front Range and kind of more populated areas, their call volume tends to be a lot higher. And for any of you who are already in this type of unpaid professional work or are thinking about going into it, I guess one pitch I'll make is that if, there's an inverse relationship between your call volume and the amount of training that you need to do. So, in a team like ours, who's really not getting a lot of calls, we have a ton of area that's extremely rugged, not very accessible. And it tends to be, not that any of us, myself included last month, heli skiing when I tore my ACL, it's not that any of us are immune to needing help, but we don't tend to, we certainly, a lot of our folks are equipped to get themselves out of a lot of situations. Of course, there are limits to that, but that often reduces our call volume. And so if it is going to be for us on kind of some of the more prevalent peaks and things like that, it's often, forgive me, but it's often, tourists and folks in from, that aren't as familiar with the terrain and things like that. But we've got lots of locals that get in trouble as well. And I'll highlight that when we talk a little bit about that avalanche caveat that we're going to address. Alex said that you might want to hear a bit about working and living in different places. Why the heck am I doing that? And does it make any sense? No, it doesn't really make any sense. It certainly is not financially reasonable. Ecologically, it's terrible. I mean, my carbon footprint for commuting to work with 2 flights is abominable, and I apologize to everybody for it. I was in the grind of loving all the resources that the Harvard scene had to offer when I was on faculty up there, and loved the Boston area. I was finding it really, really difficult to get outside, and had a major medical scare during that time. Thankfully it was misdiagnosed, but at the time was told that, I only had 5 years to live. And so life became very focused on, oh my gosh, what do I want to do with this limited time? And I think it's something that still carries with me now. And so not necessarily all about chasing the dollar or about, kind of that balance of wanting to certainly be a responsible human being and want to contribute to our medical community and do research and do lots of volunteer service and kind of offer back in those ways, but also kind of trying to make sure that not, living for retirement or waiting and deferring a bunch of life experiences for some time that may never come. And so, and that's really highlighted with all the events, again, back where I live, it's I'm not sure that I've got a single partner that I backcountry tour with and do some of these higher level activities with who has not been swept in an avalanche. So not that that's something to be proud of, it's not, but just the idea being that, you need to make careful decisions, but you also, never know when your time will be. And so hopefully we're each being good to each other and taking advantage of that on the time that we have. When I transitioned from Massachusetts to Colorado and was really enjoying access to being outside, I joined a private practice. So I went from the academic world and pediatric academic world for pediatric anesthesiology to private practice in the adult zone, and started to get a feel for how messy the business of medicine is. Apologies, there are some, I've got some negatively toned messages tonight. We lost our contract with the hospital after a year and a half of me being there. I knew I wanted to stay in Colorado, didn't particularly want to go to the Front Range. Apologies to any Front Range folks that are there. The Front Range is great. I was hoping to live in a more rural part of the state. And there was only one spot that I could find at the time. The market now is much more wide open. And at the time it was pretty restrictive. Investigated, and that was a practice, which I won't name. There are a couple practices in Durango. It was one of them. Our practice was also a mess. I knew it was a risk going there. They had really high turnover in their anesthesiologists, about 60% every year and a half or so, which is terrible. And thought I'd take a shot at it, and and it was terrible. That practice no longer exists either. So, my point in all this, and I'll share a little bit more to explain kind of this cross-state thing, but some of this stuff we don't plan out in life, and most of us don't keep our first job outside of training. So I'm not suggesting that you just throw caution to the wind and just, not spend a lot of time investigating your options. But some of this stuff is just going to kind of roll and happen. And so, I can identify with being super stressed out as a student and trying to kind of lay all the plans out. And I think a lot of our responsibility is to appreciate that we actually have a lot less control of things than we think that we do, and kind of just roll with the punches. So at that time I tried, I was trying to decide, do I attempt to stay in Colorado? Do I move from Colorado? I really didn't want to move for the job. And so I started just living where I wanted to live and then working where I wanted to work. I did some per diem work, and I'm hoping, I'm gonna check the time real quick, to chat with you guys a little bit about that tonight too. Some of you may be interested in sort of how to structure that, what the per diem work looks like, differences in W-2 compensation versus 1099 and things like that. And certainly if there's not time tonight, let's find a way to connect by phone or by email if you have questions on all those things. Same with establishing business practices and with billing practices, which I've learned a lot about in the last decade. So that gave me an opportunity to still enjoy where I was, but to travel. Would these things be possible if I had a family? Yes. Some of my colleagues have done it with kids, but obviously it adds additional challenges. And so, again, we're talking about this elusive work-life balance. It really doesn't exist, right? We all have to make these choices of what's important to us, know ourselves well, and know what's worthwhile for each of us and which sacrifices we're willing to make and not make. And sometimes that changes over time too. And so trying to be adaptable to that. I was doing per diem work at a number of institutions, pros and cons there, lots of scheduling flexibility, but not a lot of job security. If they're needing you for per diem work, it means that they're shorthanded. Their goal is to no longer be shorthanded. And so, once they get staffed up, then they're less likely to need you for scheduling. The Vanderbilt Association wasn't something I went looking for. It kind of fell in my, we've been trying it out for about a year and a half. I love being at Vanderbilt. It's one of the most pleasurable working environments I've ever had. One of the drawbacks, and again, if you guys are looking at kind of your career options, being on faculty and having a W-2 arrangement with them my travel is not compensated. Whereas when I was doing per diem travel work, it was. And so, lots of issues and financial implications with all of those things. But it's super fun, really, really pleasurable to be able to interact with residents and students and SRNAs and get that kind of interaction and that teamwork approach instead of being, alone in a room. I don't know if we have any anesthesiologists on tonight, but sometimes it can be a lonely world in the world of anesthesiology if you're not doing care team model and you're just passing gas, as they say, on the other side of the drape for hours and hours and hours every day. That also has its benefits though as well. So, living and working in different places is not something that I sought out to do, but I think part of the point tonight, and I think part of what Alex maybe was interested in, and you guys hearing, is that you can structure a lot of your life however you want it to be. And I think we tend to have these set ideas about what it's supposed to look like, but it's actually probably a lot more flexible than we each think that it is. And not that there won't be sacrifices to make it what you want, but it definitely is possible. Rural medicine, and there may be some of you on tonight in rural medicine, and I'd be interested to hear from you, also has its pros and cons. I enjoy being able to be at a major center with more recent technology, efforts to follow best practices, and efforts to stay current relative to what I experienced in small town medicine. And I don't mean that as an insult to small town medicine, because it's it also has really cool aspects to it. But having that balance of being able to work and live in different places is offering that, where you don't have to live in a city. You can have access to the mountains and to the desert, or to the, whatever your jam is. And then also have access to modern, more modern care. Let's talk a little bit about Bert and Jeff real quick, and then we'll dive back into some of our other topics here. So this incident is from December of 2020. And just for orientation, this 550 that you see on the right-hand side is our major thoroughfare. I don't know if any of you have ever heard of the $1 Million Highway, but that's worth a whole hour talk in and of itself. Just an incredible stretch of road, lots of old tales about why it's called that. You can see Silverton listed there. Ouray is north of that. Our town, Durango, is just south. And in fact, just when I was coming on Zoom to meet with you guys tonight, I got a ping from our EMS system. What we get for calls on 550 are a lot of embankment rescues. And so in fact, tonight there's another vehicle off the edge. And it's too bad I don't have any slides of that for you today, because it's a very dramatic stretch of highway and very, very steep falls and lots of sections where there's no guardrail. And the reason for that is because we tend to get an enormous amount of snow and avalanche activity on the road. And so we need a space for our amazing CDOT folks who are incredible, who maintain that roadway. They need a spot in order to shove the snow off, or else the road gets closed. And so there's not a whole lot of protection. So hopefully that the folks involved in the incident tonight are okay. It sounds like some serious injuries though. On this particular day, Jeff, who's spoiler alert, one of our anesthesiologists in town, and his friend Bert, they went out for a ski tour in that area, specifically known as the Battleship. It's a zone that's low angle itself, but the trouble is that it's got significant connected terrain. And they went out for a ski tour. The prior day, the forecast for the day that they went out, so that the tomorrow's forecast was that the avalanche risk was going to be not low, but lower than what our forecasters wound up offering in their forecast for that day. So it was considerable avalanche risk that day that Jeff and Bert went out. And late in the night, one of their wives, I think it was Bert's, but I don't want to misquote that, actually notified authorities that these guys hadn't come home. They knew where they were planning to be. And so our teams, we worked in mutual aid with the folks in Silverton, and our teams went to the trailheads and identified the vehicles and made some efforts to kind of assess the area. At some point later, I don't know if that was not that night or the next day, we actually found out that some other skiers in the area had seen a large slide off of the battleship. And that was noted by about 2:30 p.m. Now, by now we're talking, it's already, 10 p.m., 11 p.m. If you're already involved in mountain rescue type stuff or other forms of wilderness medicine, you probably know that once we're looking at issues that are switching from a rescue to a recovery, then it becomes important to really slow the activity down for the sake of the rescuers, because most likely in those circumstances, the work that you're doing is not going to result in a change in the outcome. And so there was still some avalanche risk. It's night now, we can't see. And so the difficult decision was made to go ahead and call off the search that night. Well, a few of our friends and associates, a group of 3 people, one of them's an emergency medicine physician locally, went ahead and forgive me, I'm trying to be very delicate how I phrase this. Depends who you talk to. Either they poached it, which I don't think is really what transpired, and went in on their own, versus, requested permission, which we really couldn't provide, because if we were saying it wasn't safe enough at that time for searchers to go in, then it wasn't safe enough for our friends to go in. Regardless, they went in that night, found Jeff and Bert deeply buried around midnight. They were able to get the bodies out. I know that you guys have had some talks on avalanche. I teach avalanche rescue. If we're geeking out on that some other time, we can talk about some of the nuances of it. But just a reminder for those of you who may not spend a lot of time in avalanche terrain, one of the things that you're taught is that you need to be trying to swim as much as you can when you're in motion to keep above that stuff and to stay on top as much as you're able to. Once it stops, it sets up very quickly like concrete, and shoveling it out is incredibly difficult, and trying to get out of it as a person buried in it is incredibly hard. You can do a lot for yourself if you save yourself a little bit of an air pocket. And so the training is that you try and get your arm in front of your face if you can, to preserve a zone for some air. And then you try and get an arm up, if you're able to, poking up above the snow. And the sad bit is that when Jay found Bert, his arm was up above the snow with one of his poles. And so he was probably trying to signal to Jeff, like, hey buddy, I'm over here. But Jeff was even more deeply buried than Bert. Both of them did deploy their avalanche bags. Unfortunately, that technology, and I wear one in some conditions, but that technology does not save you from a burial. And what we think transpired in this incident, from all the information, this was unwitnessed and there weren't any survivors, and so we can't get any witness accounts. But what we think transpired is that there were some sympathetic releases, and we know that there were sympathetic releases, but we think that there were also some secondaries. And so it appears that they may have been buried a few times over. And so even their attempts to swim up above it, if you now have a new, once you've been arrested and the concrete is starting to establish, if you have a new deposit of avalanche debris coming down onto you, you aren't in a position to be able to move with that. Whether or not that was the case in this particular incident, we've got a couple other case studies of avalanches from our area that absolutely was part of what transpired. In the red, you can see that was the release that caught Bert and Jeff. The orange circle is where their bodies were found. The blue and the yellow are additional sympathetic releases. And very difficult to ascertain from this photo from CIAC. I didn't put some of the other ones up, but what's interesting is they were actually in very low angle terrain, and low angle terrain is known not to have high associated avalanche risk. But unfortunately, the shape of this beautiful feature battleship and particularly on the face that they were on, because we ski multiple faces of the battleship, but they happened to be on this particular face that day, and it's connected to some very, very steep terrain. And so the trouble is, yes, they were on low angle, but they released such significant debris from the high angle section that unfortunately it came down on them. And from all our context clues, position that their skis were in, and some other things, it's apparent that they were most likely even still skinning up, hadn't even been able to start enjoying their turns. We think that they did a lap, came down, and were working their way over through the trees, and got swept. Another shot indicating that face of the battleship, and the yellow circle is the approximate location of Bert and Jeff. The little bit of the image of some of the slide debris. Jeff had twin boys a month old at the time that he died. And then this is one of the snow pits that was dug by one of our forecasters when they were doing the analysis. Lots of faceted snow, and so some weak layers that definitely allowed for crack propagation, and allowed for that big slab. The bodies, we don't try to recover them in the middle of the night like that. And so Jay, after getting them out, went ahead and, respectfully got them, covered appropriately. For those of you who might be involved in some of this work, you probably know one of the techniques that we're trained in is, when you're doing your beacon searches, other signals can interrupt them. And that was a key playing deal with, we had a bad season this year, that particular year. Just a few weeks in a very close location, we were on scene for a triple fatality. And beacon confusion was a major part of that recovery mission. So that's a talk for another time. But initially when you locate, if you've got a multi-burial, initially when you locate one, you'll do your best to find the beacon on that person and get that turned off, so it doesn't confuse the rest of your search for the other parties. But once you've concluded all that, so once Jay had Jeff and Bert up on top of the snow, part of their job was to actually turn those beacons back on when you're leaving a body for a later recovery. And that's in case there's additional avalanche activity in the area after you've uncovered them. And so, if they were to get secondarily buried again, that you've got a source locator for them. So another sad loss for our community. All right, I would love, so we've talked about a few tipping points, and I'm hoping that we can just open up for conversation. A couple of my additional kind of sad disclaimers, and I think you guys already know a lot of this. I referred to a lot of this work. Sorry, the train's going by again. I referred to a lot of this work as, unpaid professional work. And, if any of you are asking, hey, how can I get into wilderness medicine? One of the most important parts of it is to simply be out there and do what you love. I don't make any money doing what I do. I accept a very, very, very modest payment as medical director for some of my positions, which, since most of these are 501c3s, so nonprofit organizations, I wind up actually giving back in the form of a charitable donation. You may have had some rare speakers on that offer that this is something that they're able to make a living at, and most of us frankly don't. It's just a combining of our love for doing things outside with the fact that we happen to have some medical education and training. And the truth is that a lot of the medical work that we do in these austere environments is not that complicated. I can intubate somebody out in these locations right now. Here's a picture of the sun coming up on Sneffels. We were just doing an early morning ascent of one of the 14ers in the area, and this is one of the spots on the way up. Offers some nice views. no problem can intubate somebody up there. But the reality of maintaining mechanical ventilation for somebody when you've got to get them out for hours and hours in really difficult terrain, it's not practical, even if you've got lots of hands. And so a lot of what we do in these austere environments isn't really technical medicine. It's just small wins. It's keeping people warm. It's keeping people hydrated. It's simple stuff. You can certainly do it with more confidence when you've got a DIM and you're, well-trained in these fields. But probably the most important message about being out and doing this stuff that you love and being in wilderness medicine is to be confident in the terrain that you're traveling and be able to take care of yourself. And then you're going to be, of much higher value to either yourself or your companions that you're, recreating and training with, and then certainly to subjects that you may be responding for. This is one of our little hot springs. Used to be kind of a secret area, but I think somebody put it on one of like the tourist blogs or something. And so now when you try to go up there and get a bath, there are a whole bunch of people there. But somebody years ago actually formalized it. It's just a natural bubbling hot spring, but somebody actually pumped it and put a bathtub there. So there's a little spot to rest. It's pretty nice. Not quite hot enough when it's super, super cold out, but it's a nice spot. We've alluded to a bunch of stuff, but I'd love to get more into the nitty gritty of what might be helpful to you all. So I'd love to open up to questions.
Do you have any recommendations for like getting involved in wilderness medicine while we're still in med school?
Yeah, I mean, what do you want to do? WMS is definitely valuable. I've been involved with some other wilderness organizations, wilderness medical organizations, and they continue to rise to the top. Other organizations that we're trying to partner with them, I'm continuing to see are actually becoming more enmeshed with them. As far as if you find yourself, being in a position where you need to write policies and things like that, WMS is doing a really good job of staying current with best recommendations, and the group of folks that they've got that are, reviewing the data, and they're trying to do it in as scientific a way as possible. That's excellent. That's furthering, the field of wilderness med, which right now is really not there's a lot of anecdotal and not as much evidence-based. And, one of the efforts is to try and improve on that. So I'd say getting involved with organizations like WMS, part of the point of going to WMS conferences, being involved in the organization like you guys are, doing a DIM, a lot of it's just about the community that you're forming and the people that you're with. Sure, you may grab some extra credentials, but it's those relationships that you're forming, and it's the folks that you're spending time with. One of the first wilderness med things, I used some of my residency fund money, which was supposed to be for textbooks and stuff, but I used it to go climb Rainier. And and maybe some of you can relate. Hopefully you're scheming ways to do similar stuff. And it just so happened that I was teamed up with Bob and Stephanie Quinn on that trip. And years later, Bob was president of WMS, and we still keep in touch all these years. Same for, Jamie, who's the current WMS president, who happens, and hopefully we'll touch on this if you guys are interested, who happens to be an anesthesiologist. By the way, Bob is not an emergency medicine doc. He's orthosurge. And so, get involved in wilderness med. I'd say, unfortunately it does cost money and time, and that's no bueno, but, finding ways to be involved with some of these organizations, not necessarily because you need that label or because, the DIM is not going to be for everybody. It's pretty rigorous and expensive, and it took me, years to get it. You don't necessarily need those letters after your name, but the folks that you're going to meet and get time with during that process and those relationships that you're going to form are really valuable. If you have a local, depends where you're at. If you have local rescue organizations and things like that, that's fantastic. They certainly do exist in in urban areas. And some of you may even have more information on that than I do. Maybe you're linked up with some of them. That's fantastic. There can be long waits. Our mountain rescue team has not accepted new members in years. When I came to them, I, had an MD, had a DIM, had a FOM, had my certs in AVI1, through the DEM process and some other things, had tested for high-angle technical rope rescue, crevasse rescue. I still had to wait 2 years to join my local mountain rescue team. So, sometimes it's kind of a matter of like, if you want to get involved in some of these fields, sometimes it's a matter of patience and being, being the water that's slowly dripping the canyon out instead of, being some dynamite that comes in on the scene. And so a little bit different approach, but often just being present, showing up and being around. Another quick note, and this is I'm checking the time, apologies. This is tangential to what you're asking, but most of the positions that I hold, and I'm on a bunch of different committees. Some of them are anesthesiology, some of them are peds anesthesiology, some of them are wilderness medicine, some of them aren't related at all. Service I'm giving back to the honors program I was in undergrad. Those invitations just come from being around and being present. And so it can be hard early career to make those decisions. It's getting easier and easier over time. And I guess full disclosure, I'm solidly mid-career now in my late 40s. The pick that's from my profile is a 10-year-old pick from my Harvard days. So you can tell there's some more wrinkles now. But it's becoming easier and easier over time to kind of discern where I should use my time and how I should use my time. And I recall, and I don't know if any of you are in this position now, but I can recall earlier in my career having a little bit of a hard time deciding, well, should I put time towards this or towards this? Where should I be putting my time? And, the answer is you don't always know. Dive into as much as you can, but be careful, because obviously if you're spread too thin, that's a problem. And kind of listen to your heart. Are you enjoying the work that you're doing on one committee or another? And the real key is not just the type of work, but the people. I mean, you're looking for people that you really enjoy spending time with, and that can help guide you. But just kind of showing up. And yeah, as far as options for doing that in more urban environments, I'm going to have less ideas about that than for rural ones. But certainly organizations like the one that you are all participating in tonight, and then and WMS would be good starters. Is somebody, I'm gonna interrupt the flow. Can somebody give me a little synopsis of who we've got on and what their areas of interest are?
Yeah, we got people from all over. So I've been seeing all levels of med students, residents, PhD pathology students, NP, EMS, APRN, PGY 13, search and rescue. So all kinds of stuff. And then really all over the country, from Virginia, Delaware, UVA, Vanderbilt, Northwestern, Idaho, Georgetown, Tampa, Delaware, Iowa, Ohio. I mean, we got everybody out here. So
nice.
pretty good mix.
Yeah, I mean, Alex, you wanted me specifically to talk about anesthesiology because most of you folks have been emergency medicine. There are some obvious parallels, emergency medicine and wilderness medicine, but really all the fields offer a lot. My plug for anesthesiology is we're not just airway jockeys. I think a lot of the other fields, associate that with us because we'll either, we interact in that capacity. Either, we show up on the scene for the code because somebody needs help with an airway, or we're training other people in airways. But, we do a lot of resuscitation and just the volume, stuff happens quickly in the OR, quicker most likely than most of the other areas of the hospital. In my old days when I was training in general surgery and doing a lot of trauma, I'd say that, for the volume, we get a lot more of tenuous things happening even in the OR than in the trauma bay, where it's just more feast or famine. And in the OR, it's depending on what the nature of the work you're doing is kind of full on. And so just developing that pattern recognition for sick or not sick, is this person circling the drain or not? And just kind of being able to, identify that from across the room is really, really helpful. So masters of resuscitation were really good at getting access. I'm going to keep bragging about our profession. This emerging world of nerve blocks. I mean, that's just the coolest applied anatomy and physiology. I just had had my colleague give me a couple of my own nerve blocks here with my ACL just days ago. And there, there's so many emerging applications now with more portable ultrasounds. I'm imagining maybe you guys have touched on that at some point, of all this good stuff of applications for ultrasonography in austere environments. Not saying that we're the only field that's playing with an ultrasound probe a lot, but we, certainly do, especially if we're a block heavy, in a block heavy practice. But you know what? Pursue what you want to do. If you're trying to choose what you're going to go into, no discredit to my emergency medicine colleagues when I was trying to choose, and I initially was misguided to the wrong side of the drape and was going into general surgery. It was because when I was down in the ER, all the really, and I was young and impressionable and I wanted action, which also for most of us slows over time. I wanted, to get in on what I thought was the good stuff. And so I wanted to do all the trauma and all the, all that stuff was going to my general surgery colleagues and not to emergency medicine folks. And so that was kind of something that guided me in that direction. The switch from general surgery to anesthesiology is a topic for a whole nother time because we're running short on time. But in short, it's really allowing me to do a lot of stuff. I've got great scheduling flexibility. I can take big gobs of time off and go climb mountains. I mean, these are incredibly selfish things, but, seeking out a practice where you're not, and there's so much value into having a practice where you have a shingle up and you need to maintain a patient base. But, even, several of my surgical colleagues, even with this injury that I'm dealing with now, have pulled me aside as I'm hobbling around the ORs and my crutches and things like that. And they're saying like, yeah, I don't do stuff anymore that puts me at risk, because if I can't keep my clinic open, then I'm in trouble. And, fields like emergency medicine, fields like anesthesiology, and apologies, because I am talking more the MD based and DO based stuff rather than all these other fantastic career options, RN and EMT and things like that. But if you're looking at, medical degree professions, then things where you're not having to maintain that patient base on your own and you're more of a, I hate the phrase service industry, but where you're more in a service industry are going to offer you more options for when you want to go to the Himalaya for 3 months. You're going to have more ability to do that. I do have surgical colleagues who only do per diem work. And so, is it possible to be a dermatologist or a surgeon or a something and still do wilderness med and still go, to be on Denali or at Everest Base Camp for months on end and treat patients at clinic? You can do that. But again, they're just sacrifices with all these choices that we make. I think there was something popping up in the chat, but I didn't see the latest.
Yep, we got a good question from Alvin. So as an MD, how often are you boots on the ground versus kind of on the back line of things, providing advice or instructions?
Fair enough. And I think right now you're talking about mountain rescue stuff as opposed to anesthesiology, because sometimes I feel like in the backseat in the OR too, if I'm working, I hope there are CRNAs in the group somewhere. You may know that sometimes there's a spirited relationship between MDs and CRNAs. So if we're talking mountain rescue, fair question. Certainly when I'm away, if I'm somewhere in cell coverage, I still will monitor missions and be available to intervene with any kind of with any kind of medical stuff. But when I'm in town, when I'm home, I'm spending a lot of time training. I'm in the helicopter at least once a month. I'm, doing our technical rope rescue stuff. Depends on our training frequency, but, your ability to make patient contact and to be on the sharp end of getting to do that kind of stuff, a lot of it is on your proficiency for moving in the terrain that you're in and your fitness. And so, I'm getting up there now for being able to keep up with our 20-year-olds and things like that on the team. But that's part of it, is training, and kind of, at least in our area, I can't, maybe you guys could offer what you experience in your zones, but the expectation is kind of to maintain at least an hour of exercise every single day. And then of course, sometimes it's many, many more depending on, what we're doing. 2 days before I tore my ACL, I did a different version of a South Grand Canyon rim to rim than I've done before. So that was, 6,000 feet in elevation gain and about 19 miles. And knock that out, and wasn't super fast, but it's a day thing. It's not like an overnight trip. The expectation is to stay really, really fit. If you're not doing that, then your opportunities to make patient contact and to stay on the sharp end of things are going to be really diminished. And so a lot of it's kind of dependent on how much time you're spending in the terrain and how fit you're staying. But you can still be of a lot of help on the radio or on the phone as people are calling in. But again, I think I had an impression that I've got all this training experience and let me combine these worlds. I can be of so much help. I didn't seek to do wilderness medicine. I was on a number of high peaks and people pulled me in knowing that I was an MD and asked for help. On Kilimanjaro, we had somebody who had, an acute abdomen. And so they asked me for some help on that. On Aconcagua, somebody die, unfortunately, most likely of cerebral edema. We had another person with some bad pulmonary edema. So I was pulled in to ask for that. These were things that were before I had completed my DIM. And, especially when they were coming to me with high altitude medicine questions, it's kind of like, I don't know, I think we give some steroid and send them down, and after, several years and a lot of money to get the DIM and a lot of great training, now I can confidently say we give some steroid and we send them down. Keep it simple. A lot of the medical stuff we provide isn't all that. I don't want to diminish our value, but there are big wins with small things that we do in these environments. And so a lot of it's not highly technical medical stuff, but I can understand how for somebody who's not in the medical field, they could have questions about how to help a patient, or they might be afraid of a situation going on. But, I'm sure you've heard it before, and movement is definitive care. And most of what we're doing is getting somebody out for treatment as opposed to treating on the scene with rare exception. That was a whole bunch of stuff that you didn't ask, but it's a good combination. It depends if I'm in town or not in town. And if I have a torn ACL or not.
Thank you.
Yeah, sure. One of the compromises, as another caveat of kind of doing this kind of mixed practice of living in one place and working in another, is that, I mentioned it doesn't make any financial sense. I'm considered a full-time employee at the university, but at a fraction of a full-time equivalent. And so, I take a pay cut in order to facilitate the travel. So none of it makes sense, but it means I get to be outside. And yeah, you're in a zone where you've got to wear your mask right now.
Yeah, I'm in the hospital right now, so unfortunately.
Yeah, hang in there. Hopefully you're not there too late.
Dr. Brainerd, you touched on like locums and per diem kind of stuff. I think there's a lot of anxiety in the training stage of like, am I going to do academics or am I going to do community? And people kind of think of these as two completely separate tracks. So could you just talk about kind of how it's been alternating between those, and whether there's been a barrier to entry or if they're kind of welcoming you back with open arms on either side?
Yeah, and even I'll definitely do that. And even switching between the adult and the pediatric world. Academics, private practice, these different fields. Yes, it is like riding a bike. If you've got a solid foundation in any of these things, it's bumpy, switching back and forth. But with short time, at least I've experienced, and my colleagues who've done some similar stuff have expressed similar experiences where you're just able to swing back into it. It is interesting, the biases. I was told many times in rural practices that they did not want anyone fellowship trained, and they did not want anybody from the academic world. I don't think I've experienced the opposite, at least in today's world. Maybe 30 years ago, there was so much pressure to publish or perish that it might have been harder to move from private practice back into academia. These days, most of these academic practices are telling me, no, we want some people that have been out. It's a better experience for the residents to be able to interact with some folks who have done it on their own instead of just being in the academic world. Yeah, I mean, you can't really overthink it. I would definitely encourage people to do additional training. I can speak obviously most confidently from the anesthesiology world, and the fellowships that are available out of anesthesiology rather than other fields, but I think the concept applies. It's becoming more and more competitive. There are, unless you've got family reasons or restrictions not to do it. And it can be hard when you're looking at, additional years of training for minimal income or getting a real job. It's very tempting to get that real job, but I think that training's never going to leave you. I have a friend who did, this is years ago, again, I'm an old lady now, but who did a cardiac surgery fellowship and never used his cardiac, but he uses it every day, right? So even though he wound up just going into general practice and not doing hearts or thoracic, that training is with them. Even when I'm not treating a PD patient, there are definitely aspects of all those years of PD practice that I did that are affecting it. So I would encourage people to do that. Yeah, if you're making that, you're right. It's not necessarily a complete divisional switch between the very binary situation of academia versus private practice. And then we've got all this community practice that's coming in that's kind of melded. Even within our system, Vanderbilt system, when I'm downtown at the the mega mansion zone, I certainly do have an opportunity to interact with more trainees. And then still within the Vandy system, when I'm working, an hour east of the city at the Wilson campus, we don't have any trainees. It's some academic folks, some surgeons that are academia and et cetera, but a lot of community folks where, again, speaking a bias from our field, but some of those relationships are different, and some of the ways in which you interact with a private practice person who's choosing to bring you your business versus an academic folk who, are restricted within that hospital system. Those relationships are different. There's so much to go into it. You got to follow a lot of your heart and get out of your head and think about the people that you're going to be with. The people are really important. And then, for me, and I think for a lot of you, if you're on tonight, then you enjoy being outside most likely. And so a lot of it's going to be the zone of where you want to be. And I think those are some things that are going to guide you much more than the job itself. And the job will change. For anesthesiology, you'll enter a job that's MD only practice without a care team model. And then within a few months of entering the care team or entering that practice, the care team model changes, and they adopt care team model and hire a bunch of CRNAs. All of a sudden your job has changed. I've taken jobs because they had home call and not in-house call. And then within a couple months of taking the job, they switched from home call to in-house call, or I may have just said that vice versa, but you get the idea. It's, try not to hang on to too many of those details because those are going to evolve as the practice evolves and as healthcare evolves.
Awesome. All right, we got two last questions here. I want to be respectful of your time, and we're already at the top of the hour. Just got really quick ones for how large your SAR team is and number of missions per year / training level of members. And then there's one more question and we'll wrap it up. Thanks.
And it looks like that's the SAR team stuff is coming from Larry. Oh, Larry, if we could talk about the politics on our SAR team. There's a lot of personalities there. Right now we have a large number on the roster. We have more than 100 people on the roster. How many of those are actually fully involved and mission ready is quite a bit lower. Due to some restrictions within our leadership circles, we've set in place some things to keep people active, and none of that's being enforced. I shared too much. The number of missions per year varies, of course, but honestly, right now it's crazy. I mean, we're only getting a call every month or so. I mean, it's incredibly small. And then, hunting season will come around, although we had a quiet hunting season this year, but then, we'll have a lot of hunters who either have gotten themselves stranded and are risking some hypothermia and frostbite, or, obviously other injuries given they're out hunting. So weapons and things. Summer can be busy, and then obviously, winter with avalanche activity. A lot of what we do is mutual aid. So it might not necessarily be calls that are within our district, but we're being asked by the Silverton team or another team to come and support them. Medical training. So out of 109, I think that we have on the roster right now, again, some of those are not active members, but we keep them on right now anyway. We only have right now 3 MDs. One of them's not super active. One of them's intermittently active. We've got a number of nurses, paramedics, EMTs. We have stopped encouraging our teammates to specifically pursue EMT level training for the purposes of SAR. And that's because they're coming to me asking me to sign off that they're maintaining proficiency with patient skills. And if they don't have another agency within which, that they've got a framework to do their training, I'm not really able to say if they haven't touched a patient in 3 years that they're maintaining their proficiency with that. And so WFA or WFR is really the highest that we're asking our members to do. And of course, we've got a lot of folks who are EMT paramedic from either our local fire rescue or neighboring fire rescue who are with us. And that's great if they've got another agency where they're able to maintain those skills, and that's fantastic. But unfortunately fortunately or unfortunately on our team, we don't provide enough to maintain those skills. I hope that touches on what you're asking, Larry. Come join our team and up the quality. And then how do you go about finding locum work? Can locum work be done part-time? Absolutely. So is it Neha or Neha?
Neha.
Neha. Well, can I ask what field?
Yeah, I'm actually in anesthesia, so I'll be in residency.
Oh, well, we should, let's dive into this. Let's take this offline. What I will tell you is, if you give your information to one recruiter in your life, you will be called and texted and emailed. I probably received a dozen today alone. So the recruiters have high incentive to get in with you. For anesthesiology specifically, there's an old website from, I don't know, from the day that the web started. It's not very well maintained, called Gaswork. You're probably familiar with Gaswork. And that will have some locum stuff. It is truly like an ancient website, but people are staying current with it. Yes, locum work can absolutely be done part-time. Know that unlike our RN colleagues who tend to benefit from doing per diem type work, and often there's a salary bump involved with the travel and stuff like that, for most of the locum work, it is not, it's going to be commensurate with what you'd be doing in a regular job. And so you can do it part-time. You need to be very careful about how your contract is with wherever, say you have a full-time gig and then you want to do some side work, which I also recommend, but that's for another time. Not a bad idea to keep your toe in a few waters, but you need to be careful about restrictions on the locations and things of that. So there might be geographic restrictions on where you're doing that, and et cetera, et cetera. Yes, people love to say that non-competes are not enforceable, and I think that's largely true. However, if you find yourself having to hire attorneys and things in order to fight a non-compete, it might not be worth it because it might be awfully expensive. But yeah. Johnson, yeah, please. I'm going to give you my Gmail. It's easier than my Vandy. And so my Gmail account is there in the chat. And then Crystal, I'll try to catch yours separately, it looks like, unless you feel comfortable talking about it or if we're out of time. How else can I be of help to you guys? Please reach out if there's any questions I can answer. If you ever want to geek out on avalanche stuff, let me know. If you're going to be coming through the Durango area, let me know. If you're going to be coming through Vandy, let me know. And if you're going to be climbing anything cool, I definitely want to know, or skiing something rad, I want to know that too.
This was an awesome talk. Thank you so much, Dr. Brainerd. Thank you everyone for coming, and we'll see you guys back in the fall. So keep an eye out on your emails for our schedule. Hit us up if you have any amazing speakers who you would like to see in our lecture series. And thanks again for y'all's attention and questions. This was an awesome talk.
Thanks, Alex. Thanks, everyone. Christopher, I might lose access to your question here, so maybe hit me up by email if I'm not able to catch it.
All right. Thanks, y'all.